Good evening, everybody. This is the membership meeting of the Property Owners Association of the Villages. Thank you all for coming. Would you all please rise so that we can salute the flag and remain standing briefly to salute our veterans and first responders. I pledge allegiance to the flag. Thank you. My name is Dan Warren. I'm Vice President of the Property Owners Association. Reb Benson, our president, is in Seattle, having fun with his family. So I get to substitute for him tonight. We have a very interesting presentation for you this evening. And I'm glad that you took the time to hear what Dr. Anderson has to say. However, a couple of things before we get to that. First off, I'd like to acknowledge Realty executives. For our meetings, we have various groups that come and make themselves available to you to provide information. So if you are interested, we'd encourage you to stop by after the meeting and see what they have to offer. Periodically, we offer an opportunity for those in attendance to ask any questions of our board members. And why don't we do that now? Does anybody have any questions, any burning questions that you think we might be able to help with? Yeah, right, that are not on Dr. Anderson's presentation. We'll get to that when he's done. Wait for the mic, because we're live streaming this, and we also record it so that anybody that has not had a chance to attend the meeting can hear what the doctor has to say in this case.
In one of the district meetings, quite a few weeks ago, over a month ago, they were talking about possibly changing the gate system. Have you heard anything about that?
Yeah, we have. I'll turn it over here to Cliff.
There's talk about them changing the gate system. What's going to happen, and it's been approved by both PWAC and AAC, is you're going to be able to buy a sticker that's going to either go on your headlight or on your car that's going to automatically open the gate. You don't have to buy it. Your car's still going to open the gate just like it did. It's just that you won't have to roll down your window if you so desire. It'll start sometime after October because it's in the budgets for next year, so they can't do it until sometime next year. They're working out the details. They're not free. There's gonna be a charge for that. Pardon? No, they don't. Not in the villages. So just be patient. There'll be lots of information. POA will have all the information in our magazine when it happens.
Yeah, before we go on with that, I want to introduce a few folks. Cliff Weiner is our past president. He's on our board of directors. Gary Cato is also on our board of directors. Okay. Gary Search, behind you over there with the other microphone, he is on our board of directors. And where is Karen? Oh, she's the short one in the back. She's our secretary. So we're all volunteers. We all serve on the board of directors. There might be a few other folks that serve in various capacities in the villages on various boards. I know one of them. So I stand up and introduce yourself. Okay, District 10 Supervisor, thank you. There you are.
Any more?
Okay. Cliff.
I'm Gary Cato. I'm chairman of the board for District 5.
And I'm Cliff Weiner. I'm chairman of the District 4 Board of Supervisors.
And I'm Dan Warren. I serve on the NSCUD board, which is your utility for sewer. Oh, Ken is, yeah. I serve on the NSCUD board, which is your sewer, your water, and your irrigation from 466A down to 44. Also trash from 44 all the way up to 42. It's a 7-person board that's elected, okay? I also chair the Architecture Review Board, and I also serve here with these yahoos. So, and Ken Seaman, Ken, stand up. Ken serves with me on the Architecture Review Board, which we meet tomorrow. Okay. Huh?
Yeah, just a quick question for you folks. I'm curious. How many of you have actually attended one of your district meetings? Wow, that's impressive. Very rarely do we get people at our meetings, and to be honest with you, that's really where you want to be if you know what's going on. The bottom line is you elected us. We're there once a month. You can ask any questions you want. You'll find out what's taking place in your district. You have input, and when all 5 of us are sitting there, you will get answers. So I encourage you to attend your board meetings, your district board meetings. And if you don't know where they are, go online, villages.com, and you can find out when they're being held. They're usually early, and they got to get up a little bit, but it's well worth it. So nice to have you here tonight.
All right, thank you, Gary. The POA has been around for 50 years. We celebrated last fall our 50th anniversary, and we're all about you. Plain and simple. So whatever effort we put in, whatever information we present to you through our magazine, whatever speakers we bring, it's for you. Membership. You don't have to be a member to attend our information meetings. It's open to any resident of the villages. And I know that it's a real steep membership fee, $15 for the household for the year. So you might want to consider that. We'd love to have you on board with that. As I mentioned briefly earlier, we live stream all of our membership meetings. It's all about us getting information to you in the most expeditious way possible. You probably noticed you haven't had the newspaper in your driveway for probably about 6 months now. And that's because we've converted to the world of online. So we have what we now call our magazine online. And you can get to that either on Facebook or on our website, which is villagespoa.org. So either you can see a meeting live stream, or all of these meetings are recorded. And I don't know how many years back, Cliff, we've recorded. June of 21. All the meetings with all of the speakers are there for you. So anyways, if you haven't, check it out. That's where all that information on a monthly basis occurs. Okay, future meetings. Just like this one, we meet once a month. August 18th, we're at Laurel Manor. We have Bradley Arnold, Sumter County Administrator, who's going to talk about the upcoming county budget. Always a very good presentation. September 15th, the following month, also at Laurel Manor, Dr. Curtis is going to talk about Alzheimer research. Also a very well-attended meeting. October 1st, fun and games at Everglade Bingo. Okay, we're kind of experimenting with this. We've had two bingo activities. We're planning on offering that once a quarter, 4 times a year. It's been very well attended. We had like 170,000. You can see where my brain's going. We had 170 people attend. We had 10 games, and the payouts in the games, we are told, are extremely generous. The 10th, which was the last one, was $320. And the one before that, the 9th, was $200. So we have a little bit of mathematics that determines how much is paid out. The more people, the more we pay out. October 20th at Laurel Manor, the Baldwin Group is going to talk about health insurance. November 17th, Rohan, right here. Kevin McDonald is going to talk about homeowners insurance. So you can see we've got things pretty well lined out for the rest of the year, and whatever interests you, we would encourage you to attend. All right, we're going to move on now to our speaker, Dr. Norman Anderson, and I'm going to let Cliff do the honors of introducing him. He's very familiar with him, and I think you've had a few treatments.
I have. Dr. Anderson has been coming to the POA. I was president for 10 years, for my whole 10 years, and actually even before that, for probably 4 or 5 years before that. I'm not sure, but that's when I first met him. He always does a great job. I could read you his bio, but it's really boring because he's so smart and done so many different things. But I got to tell you guys before he starts talking, listen carefully to what he says. I was his first patient with this process, and I am telling you, it works. And my wife was one of his patients, and thank God she now has a quality of life that we can do things we weren't able to do for 3 years before that. We've been here for 24 years, and it was going downhill really fast. I highly urge you, you have nothing to lose, and I will guarantee you that Dr. Anderson or anyone else on his staff will take care of you. It's probably the best medical staff in the villages that I've been to, and I go to a lot of doctors. So without further ado, Dr. Anderson, my great friend, come on, you're up. Yeah, and he'll take all your questions. Just wait until he's done because we need the mic at your when you ask a question because it's pre-recorded. Thank you, my friend. Anyone you want, you're the boss.
I need to have you tell my family that I'm the boss because that hasn't happened yet. Even though I have a script laid out, I am most happy to stop at any point and discuss questions with you. I'm beginning to enjoy coming and giving lectures, and the reason why is because the audience has been so... Can you hear me? How about now? The nice thing about listening to me... The nice thing about listening to me online is that when you get tired of listening to me, all you got to do is just turn me off. Now you don't have a choice. This slide has absolutely nothing to do with the presentation. Osteoarthritis is the progressive erosion of both cartilage and the underlying bone. It seems every family has a member who suffers from its ravages. According to the World Health Organization, osteoarthritis is the most rapidly increasing health condition and competes as a leading cause of disability in the United States. As it progresses, its associated pain may become more intense. Over time, swelling in the joint and surrounding tissue may occur. As indicated, osteoarthritis is the most common type, composing roughly 85%, and affecting over 32 million people in the United States. And this is addressed with radiation. Rheumatoid arthritis will occur in the same joint space with osteoarthritis 50% of the time. Therefore, it may be difficult to quantitate the pain contributed from each, but regardless of its origin, beneficial reduction in pain from treating osteoarthritic components is real. Risk factors include number 1, a family member with the condition. Number 2, past injuries such as torn cartilage, dislocated joints, or ligament injuries. Number 3, being 50 years of age and older. Specifically, 90% of those affected are over the age of 45, with almost 50% of those affected age 65 or older. Number 4, being overweight increases its occurrence. Number 5, an occupation that involves kneeling, climbing, heavy lifting, or similar actions. Number 6, another medical condition that affects your joint health, such as a different type of arthritis. Number 7, ladies are twice as likely to experience osteoarthritis. Number 8, being postmenopausal is an additional risk factor. Osteoarthritis may affect different parts of your body. It is most commonly the knees and hips, but it may also include the fingers, hands, wrist, elbow, shoulders, the spine, now called spondylosis, which is a degeneration of the discs between your vertebrae. Commonly, this involves osteoarthritis of the neck and the lower back. It can also affect the feet and the ankles. Symptoms may routinely involve multiple joints of your body. Having osteoarthritis in one area may, at the same time, increase your risk of developing the condition in other body parts. It is hypothesized that mechanisms which produce inflammation drive the attraction of enzymes which lead to a breakdown of the joint itself, resulting in damage to bone, the surface of the cartilage, menisci, ligaments, and synovium, which is further accelerated by bearing excessive joint weight. I think of this as a pebble thrown in water, and the ripples spread out. Let's include all the ripples, even though they diminish in size, as areas of potential inflammatory involvement within the joint and surrounding tissue. Structurally, osteoarthritis can lead to joint space narrowing, osteophytes, or additional bone formation caused by the chronic frictional contact, and bony deformity, which can become only too obvious. It may also be identified on radiographic studies, which include plain X-rays, CTs or CAT scans, and MRIs. When one considers the overall occurrence for both men and women, the lifetime risk of developing knee osteoarthritis is 46%, and osteoarthritis of the hip at 25%. You see, the higher occurrence of osteoarthritis in ladies may actually be our medical proof that women work harder than men. In order to better treat patients, medicine defines 4 stages of osteoarthritis. Stage 1 is mild. You may experience early symptoms, but your cartilage is still in good shape. Stage 2, moderate. You may experience sharp, acute symptoms. Your cartilage is now showing signs of wear and tear. Stage 3, advanced. You may experience constant symptoms, especially when you apply weight to the affected joint. The joint cartilage is almost gone. And stage 4, severe. You may experience severe pain, stiffness, and inflammation with decreased range of motion, joint instability, such as sudden locking or buckling, muscle weakness, bone spurs, and joint deformity. What is the history of treatment with therapeutic radiation? X-rays were discovered in 1895, with the first patient treated for osteoarthritis in 1898, over 125 years ago. Therapeutic radiation was used worldwide until the 1960s. At that time, with the introduction of non-steroidal anti-inflammatory agents released by the pharmaceutical industry, the use of radiation for arthritis diminished in the United States. However, that did not occur in Europe, as Germany continued without pause the treatment of arthritis using therapeutic radiation. Over the next few slides, let's look at the side effects with standard treatment approaches, as well as their cost. As history has shown, the constant use of non-steroidal anti-inflammatory agents can adversely affect the health of both liver and kidney, also resulting in gastrointestinal bleeds and heart irregularities. Steroid injections into the joint space have been selectively utilized. With chronic use, this can unfortunately lead to continued destruction of the joint, and the cost becomes markedly escalated when progression of arthritis requires surgical intervention to treat painful conditions. This has been its natural evolution after administering appropriate and accepted treatments for a relentless condition. As an alternative, for plantar fasciitis or involvement of the fascia of the bottom of the foot, trochanteric bursitis, medial and lateral epicondylitis, tendinitis of various joints, and osteoarthritis of both large and small joints, low-dose therapeutic radiation has been shown to be of significant benefit. What is the potential collateral damage or side effects of having osteoarthritis? Undoubtedly associated with decreased physical activity, osteoarthritis has been shown to increase the risk of developing heart disease by 50%, and the decreased activity affects associated conditions, as well as the adverse effects of needed medications. Osteoarthritis has been shown to increase mortality by 55%. It has also been associated with higher rates of depression and anxiety. Expense makes it the second most costly health condition in the United States and responsible alone for over 4% of all total hospitalization costs. Those affected by arthritis spend an estimated average personal cost of over $11,000 per year. Total U.S. direct costs for medical expenditures are $65 billion annually. Considering the reduction of health-related quality of life in those affected and the considerable socioeconomic cost due to multiple therapeutic procedures, osteoarthritis is a significant burden on the U.S. health system. Let's look at a different alternative that can change the playing field and quality of your life. Let's view the effect of Tylenol as an analogy. If one of us were to have a headache or muscle soreness, and we took only 1/4 of a Tylenol, that dose would probably just irritate the headache or the muscle soreness. You wouldn't experience any relief. But if one were to take 2 regular Tylenol, the likelihood of relieving the headache or the muscle soreness would be markedly improved. It would have accomplished its goal. Now, at the other extreme, if one were to take an entire bottle of Tylenol at one time, it would not improve further the relief of the headache or the muscle pain already achieved, but the toxicity or side effects to the liver of its addition could result in death. Obviously, the Tylenol remained the same, but how it was taken varied tremendously. As for radiation, let's take our exposure to sunlight over decades of time. This chronic irritation from ultraviolet light can lead to skin malignancies, even though radiation can play an important component in the production of healthy vitamin D. It is a trade-off. For example, extremely low doses of radiation from sunlight can be inflammatory in nature, but slightly higher doses of therapeutic radiation administered for osteoarthritis, like the optimal dose of 2 Tylenol, create a totally different effect and are actually anti-inflammatory. That is, radiation reduces inflammation dramatically. From 10 centigrade to 100 centigrade of radiation, the biological effect is one of reducing inflammation. The ideal dose or sweet spot is that of 50 centigrade, also called 0.5 gray, for each radiation treatment given. And that is a totally different dose than used for treating cancer, with a totally different response. Although still radiation, it is an energy whose effect dramatically varies upon the amount given each time, the total dose administered, and the time interval between each dose delivered. This uniqueness will become more evident as we move through our presentation. This slide may be confusing, but it is designed to show the clinical effect of radiation at different amounts. look at them as separate compartments, as if radiation can somehow be divided into 3 unique phenomenon or threshold doses. That is the term used in the medical literature. Specifically, if the dose is less than or equal to 0.1 gray, also called 10 centigrade, the effect is one of inflammation. If the dose is above 0.1 to 1 gray, the effect becomes anti-inflammatory. If the single dose is greater than 1 gray, it again becomes inflammatory. That's the reason for the prior statement that radiation may not seem like radiation. The effect varies dramatically based upon the amount of each single dose. Suffice it to say that it is the dose of 0.5 gray in the middle of the anti-inflammatory range that creates the optimal therapeutic benefit for treating osteoarthritis. And just as critically is the time interval elapsing between each treatment's administration. There are 3 anti-arthritic biologic events that take place when radiation is administered at low doses for the therapeutic treatment of osteoarthritis. The first effect is the complete elimination of lymphocytes within the area of treatment. Lymphocytes are part of your immune system and function as an integral component of our body's defense mechanism. However, in the case of osteoarthritis, these cells within the limited involved area dramatically increase inflammation and lead to destruction of the joint. Low-dose radiation therapy immediately kills these cells on contact. Not only do the lymphocytes die, they disintegrate, literally eliminating the inflammation. However, it can take up to 3 months following the completion of treatment before its overall benefit is realized. The second effect of therapeutic radiation is that of stopping macrophages, another part of our immune system, from releasing chemicals that attract more lymphocytes into the area of the joint. Low-dose radiation modifies the behavior of the macrophages, stopping the attraction, preventing your body from completely self-destruction. The third reason for radiation success is that of modifying the blood vessels in the immediate area, whose normal porous consistency allows lymphocytes to exit the blood vessel and migrate into the joint space. Low-dose radiation causes the lining of these blood vessels to close, so lymphocytes can no longer enter the joint space. This further reduces the hostile environment lymphocytes create that leads to the medical condition we know as osteoarthritis. In essence, this treatment technique has been available for well over a century. In the clinical setting of Europe, it has been uninterrupted for the past 60 years. In the United States, less than 5% of radiation facilities have offered low-dose therapeutic radiation for non-cancer conditions. In Europe, over 85% of treatment facilities have offered therapeutic low-dose radiation. One can anticipate a 60 to 90% positive response in addressing the symptoms of osteoarthritis with the first course of therapeutic treatment. For achieving optimal results, it is recommended the course of treatment be repeated an additional 1 or 2 times, with each course increasing its effectiveness. One should allow 8 to 12 weeks following the completion of a sequence or cycle to determine the overall benefit from its intervention. Why would you repeat a course of treatment? If one were to have suffered from arthritis for an extended time, a frame of reference is lost. That is, it has been so long since you experienced no pain, there is no reference point as to how good you really could feel. You could have experienced little or dramatic relief, but you really don't know how much better that relief can become. That is why most insurance plans approve treatment for each joint space to be administered a total of 3 cycles in order to evaluate the maximum benefit that can be achieved for its maximum duration of time. Conditions such as plantar fasciitis, trochanteric bursitis, which involves the hip, medial and lateral epicondylitis, also called golfer's elbow and tennis elbow respectively, tendinopathies of various joints, and osteoarthritis of both large and small joints have been shown to benefit from low-dose therapeutic radiation. Currently, there is strong data to suggest a benefit of low-dose radiation in plantar fasciitis, or the bottom of the feet, with greater than 80% effectiveness in pain reduction. Additionally, data suggests that Dupuytren's contracture, Lederhosen disease, heterotopic ossification, and other disorders benefit. Much of the modern data has been clinically applied outside the United States for supporting the benefit of low-dose therapeutic radiation. What are the side effects of LDRT? Essentially none. Does insurance cover this approach? Insurance companies to this time that have rejected radiation as a treatment option are Ambetter and some policies of Aetna. They have claimed this experiment that it is experimental, even though we are looking at 120 years of medical results and countless studies. Their denials are unsubstantiated based upon the medical literature and deny their policyholders curative treatment. I see this as nothing more than a ploy to avoid payment. What do most insurance plans realize? The comparison in cost reveals therapeutic radiation can be delivered for less than 20% of the cost of surgical intervention if 3 cycles of therapeutic radiation is performed. If only 1 cycle is administered, the treatment is achieved for less than 7% of what a surgical procedure would cost. This is what needs to be stressed to the insurance provider. Is there a risk for secondary malignancy? And this has been an ongoing concern since the atomic bomb was used in World War II. However, it is impossible to compare total body radiation exposure with that of localized therapeutic radiation administered to structures that don't involve internal organs. The most thorough research has been done in Europe. In comparison, for women receiving radiation therapy for shoulder osteoarthritis, the incidence of breast cancer involving the breast closest to the treated shoulder actually demonstrated less incidence of developing a breast cancer compared to women having never received radiation within the region of the breast. One estimate of secondary occurrence of malignancy is estimated to be 1 in 10,000 patients, but that is theoretical, with the risk continuing to fall as our age increases. Other comparisons would place the risk as equivalent to that of completing a CT scan or a CAT scan. I know of no recorded case of a malignancy occurring in an internal organ, and thus the risk would be extremely low. However, it is recommended that patients younger than 40 years of age not receive low-dose radiation therapy for osteoarthritis. My practice's policy is we don't treat anyone less than 50 years of age, which would probably, until you all reach 50 years of age, would essentially eliminate everyone in this audience. When radiation is used for non-cancer treatment, we apply the premise that less is more. Specifically, although data would indicate that up to 1 gray or 100 centigrade can be administered with each treatment, as indicated earlier, The sweet spot would be that of 0.5 gray or 50 centigray. This dose is delivered 6 times over a period of 2 weeks, routinely administered Monday, Wednesday, and Friday. The alternative would be to receive it twice weekly on Tuesday and Thursday over a period of 3 weeks. The total dose is 3 gray or 300 centigray. This is also described as 300 rads, with the acronym RADS signifying radiation absorbed dose. Other time schedules would provide similar results. What does the medical literature reveal when a treatment sequence is administered more than once? A recent prospective study of 100 patients treated for hand osteoarthritis showed final significant pain improvement in 94% of patients after therapeutic radiation. Of note, 63% of these patients underwent a second course of treatment at 12 weeks due to inadequate initial response. 70% of those patients treated were found to have an improvement in their pain after LDRT. Patients who received 0.5 gray per fraction reported a significantly better outcome in comparison to patients receiving twice that amount. Given the principle of as low as reasonably achievable, this data now suggests using 0.5 gray each time, as opposed to 1 gray, to limit any unnecessary side effects. All our patients are treated with a dose of 50 centigray or 0.5 gray each time, and emphasizes the importance of our meticulous accuracy in treatment delivery. Why has it not been used? The results published in the journal Science by the United States National Academy of Sciences in June of 1956 are now known to have been based upon incorrect data collected from research done at Oak Ridge National Laboratory. This erroneous interpretation of the data resulted in the switch from the long-held view that there is a threshold dose response for hereditary risks of radiation to what they call a linear non-threshold dose response, which became a major pillar of the modern cancer risk assessment process. Part of the policy of the U.S. EPA and nearly all regulatory agencies worldwide. That data was incorrect. In essence, the linear non-threshold dose-response model assumes that the more radiation administered, the greater the risk of producing a secondary malignancy. That is totally false. The truth is, there are threshold doses. In this particular case, for doses below 100 centigray per treatment, and certainly at a value of 50 centigray per treatment, the dose administered is considered to be of minimal, if any, risk. The error in this data was not revealed until late 1994. As indicated in an earlier slide, the dose range used for osteoarthritis is anti-inflammatory and is proven to be therapeutic for countless lives. The ancient saying is relevant here. The fish rots from the head. That is, this problem started at the top of the scientific establishment to include a panel of distinguished geneticists with 2 Nobel Prize recipients. Practicing physicians and healthcare providers may hesitate for radiation to be given. Their training could very well have been based upon the invalid information released in 1956 and perpetuated in our education system for decades. These professionals are very caring providers who would not in any way jeopardize their patients' medical safety. And yet, what they have been taught, and that information perpetuated, has placed countless thousands of patients to be denied state-of-the-art medical care. The Robert Boystow Oncology Institute has been accredited by the American College of Radiology for over 30 years without interruption. This is unequaled in this area of Florida. We were one of the first practices in the state to achieve this North American recognition. 3 of our physicians have been selected as fellows in the American College of Radiology. Of all members in North America, 15% are so recognized, with a much smaller percent in private practice ever selected as fellows. 3 of us have been so recognized, with the 4th to receive that award next year. I don't know of another private practice entity in North America with that recognition. As a comparison, are all doctors that you have met the same? Their personalities, attitude, skill, caring? Do all surgeons have the same reputation? More importantly for the ladies, are all hairdressers the same? Would a lady have a preference as to who cuts her hair? If they're all the same, why just not go anywhere? Then why would you think about caring about how you're treated for arthritis? As to our village office, Dr. Flink and Dr. Pradhan are here exclusively and can see you rapidly. Dr. Flink was trained at Johns Hopkins. Dr. Pradhan was trained at the University of Southern California. I am available in our Villages, Ocala, and Timber Ridge offices. I have the utmost of confidence in both of these physicians and would trust them with my life. What is maintained by all our physicians is the RBOI standard of care, our rigid, optimal protocols, and our quality control. That is what makes the difference. If you do want to see me, my availability may be more rapidly occurring in one of the other offices, and since the treatment sequence is of such short duration, that inconvenience may prove minimal. We are not venture capital driven. We are patient care driven. I always tell my staff when they interview that I want everyone coming through our front door to be treated like family, because sooner or later, the person coming through our front door will be your family. And hopefully for the greater than 24,000 patients I have treated, that difference has been felt. This presentation was not intended to be a sales pitch, nor is it a guarantee of success. Each individual may respond differently based upon the specific area treated, as some demonstrate an immediate response and others with delay. In fact, the same patient response can be different. For example, I treated one ear, nose, and throat surgeon that I've worked with for decades who came in to see me with severe osteoarthritis of his feet. He was a road biker and rode his bike virtually every day, about 50 miles, and literally wore out his feet, so that he got to the point where when he walked, he shuffled, he didn't walk. He came in to see me. I treated one foot. Immediately after that, we treated the second foot, which is the standard. You can't treat more than one area at the same time, but you can move on to the next cycle immediately. You cannot go back to the original site for 3 months. That's based upon the European protocol and insurance regulations. He came back to see me 6 weeks after we were done with no benefit at all. He said, "It just did not work. I'm not interested in getting any more." 2 weeks later, now 2 months from the last treatment, he calls me in the middle of the night. That's his way of talking to me. He said, "Norm, I can't believe what just happened. The pain is gone. Like a light switch was just turned." He said, "I went from incapacitated to being 20 again. Now, how soon can you do it again?" I said, Chris, we got to wait 3 months. 2 weeks after that, he calls me. "I want my back treated. I have an MRI of my lower back. I have severe osteoarthritis of my lumbar spine. How soon can you get me treated?" So I got him in right away because it was a different area. We designed the treatment, and I started him on Monday. I saw him in the exam room that Friday. He had just completed his third treatment moments earlier, so essentially he had completed 2 treatments. He said, "Watch this." He stood up, put his hands as high in the air as he could, bent over and touched his toes. He said, "I have not been able to do that in years." He said, "Now look at the difference. It took 2 months to get the response to my feet. It took 3 days to get the response to my back." So you see, even in the same patient, the time period necessary to see the benefits can be the difference between night and day. I had one lady that I treated who is the wife of a U.S. congressman. I had actually treated her for a very aggressive cancer 3 years earlier. Everybody, George Washington University said, "There's no cure, she's going to die." Well, we cured her. Bottom line was, she calls me up. We were talking about arthritis. She said, "I'm coming down to see you." I said, "You don't have to come all the way back to Ocala to be treated for arthritis. I'll find a place for you in D.C. She said, "You don't understand. I'm coming down." I said, "Susan, please, just give me a few days. I'll call you." That was Sunday afternoon. Monday morning, she's at my doorstep. Bottom line was, I started her treatment. Wednesday, I see her in the exam room. She said, "You know what woke me up this morning?" "No, what?" "My alarm clock." I said, "Yeah, mine does that occasionally too." She said, "No, you don't understand. It has been years since I woke up on average 8 times every night because of the severe arthritis in my left shoulder. I can't get comfortable. I can't sleep. None of that occurred last night. I woke up because the alarm clock went off. I haven't felt any pain." Well, we got her treatment sequence done. She went back up to D.C. She calls me a couple of months later. "I'm thinking about retaking tennis, and I haven't played tennis in 10 years. I said, "Let's take it with baby steps, because undoubtedly, even though you may not be feeling any pain in the joint, the tendons, the ligaments, and the muscles haven't been used like a tennis player for a good 10 years. Let's get back up to speed gradually." Okay. This is the second slide that has absolutely nothing to do with the presentation. The rules are, number 1, bark at anything. Number 2, tissue is for shredding. Number 3, always follow your human to the bathroom. Number 4, always share your bed with your human. Number 5, chipmunks, squirrels, toads, and birds are for chasing. Number 6, you can never have enough toys. Questions that you have of me? Sure, of course.
The way we're going to do questions, we'll alternate sides, and we need a microphone because we record this for the benefit of others. So that's the procedure that we're going to use. So first question there.
Concerning insurance,
Yes.
generally you said it's covered. Is it
Yes.
fair to say that some companies may cover and some may not?
Can you hear me? Yep. Yes, that's a very good question. 95% of the insurance companies will approve it without question. Here's the thing that amazed us. It was my stupidity, and other doctors are just as stupid as me. We assumed that because this was a, quote, new technique, we would have to try and convince insurance companies of its appropriateness. As it turned out, the vast majority of insurance companies approved this 15 years ago. It was only started to be used in the United States in June of last year. They already figured out it was going to start. They just didn't know when. And the powers that be, they couldn't go up against the big gorillas in order to emphasize getting it started. They were ready. So with the first patient that we called up, first question they ask is, do you have x-ray evidence of osteoarthritis? If the answer is yes, they say approved. Now, are there any other areas that you want approved at the same time? And it's approved for 3 cycles. So what would have looked like a real battle, and that's a very good question that you raise, actually turned out to be relief for my staff, because I employ 9 staff members to literally fight with insurance companies all day long to get approvals. And this is when they were begging us to go ahead and treat. But you will get the odd policy. Now, having said that, once we do mention the fact that it's been done for 125 years, oh, really? And then they do their own investigation. They call us back, and they basically say it's approved. Sorry. Yes.
Are there any age limitations on the treatment?
Very good question. Are there any age limitations? The only one we put in place right now is you have to be breathing. If you're breathing, you qualify. And you know the reason why, and although it sounds facetious, pain is pain. And even though I've been treating cancer patients for 46 years, and like I said, over 24,000 cancer patients, I have found that the pain that arthritis patients bear is just as severe as any cancer patient's pain. And you deserve relief. What kills people emotionally is the chronicity of pain. If pain is intermittent, it's amazing what the human body can tolerate. If pain becomes progressive and constant, it takes you down, both physically and emotionally. And I think for those that have experienced this treatment, we reverse that process.
Insurance companies approve. What about Medicare?
They're on board 100%. If you have Medicare, you are golden. And if you have a supplemental policy where Medicare is your primary, the supplemental policy has to follow the guidelines of Medicare. They cannot delegate how they're going to pay. They have to, and the guidelines of Medicare is, it is covered.
Okay, I have a friend who has bone-on-bone
Yes.
arthritis in the knee. Does bone-on-bone eliminate her as a candidate?
That's a very good question. If you have bone on bone, are you eligible for the treatment? The response rate is less. What the medical literature would indicate is even with bone on bone, there is a 60% effectiveness after the 3 cycles. What on earth are we treating if the cartilage is completely gone? That's what bone on bone is. Think of cartilage, and cartilage is 70% liquid. It's a big, firm sponge. It absorbs the impact between your bones. If that has all been dissolved away and there's no padding left, what on earth is the radiation preserving? Because you see, we stop the destruction immediately with the treatment. So that means that whatever cartilage you have left, you get to keep. If you don't have any cartilage left, what on earth are we doing? What we found is the entire joint cavity becomes inflamed. So it's not just the cartilage, it's the bone, the tendons, the ligaments, the muscles. All of that is treated. When I treat a joint space, like if I was doing your knee, I would not just be treating around the patella. I would be covering a distance well above and well below the knee cavity, which means I am now including the insertion of all of the structures that support the knee. That has to be the basis. But we tell patients up front, don't expect the same % chance of success. But as Cliff and I said when we had lunch, I guess it was August of last year that we had lunch, Cliff said to me, if you're telling me I've got any chance of improvement, like 50%, I would be foolish not to try it. And that's been the policy. Why? When you weigh the side effects of the radiation, which is basically inconvenience 6 times, and we're so pleasant to be around, people would pay just to come in and enjoy our company. There are no downsides. Plus, I like to brag. And if someone comes in and gets the kind of results that I've already seen, trust me, I'm in my glory.
Yes, thank you for coming tonight.
Sure, my pleasure.
One of your slides, you indicated in 1994, the medical societies determined that this was efficacious
Yes.
for the for the osteoarthritis. That was still over 30 years ago.
Yeah.
So why is, even with 30 years of background and the data that some of the data you presented, then why is Europe using it in an 80-90% clip and we're still at less than 5%? Thank you.
You have asked one of the most relevant questions that I cannot answer unless you start thinking about what kind of influences could control that information, and then you may be able to figure out the answer yourself. I have 2 colleagues in Paris who are radiation oncologists. We have talked about this a number of times over the last decades, and they said, you guys are absolutely foolish for not using radiation when it's as effective as it is. I searched the U.S. literature over and over again. Nothing. I had 5 years of residency after becoming an MD in my specialty. Not one word was ever spoken. I've been in private practice for 41 years. Not one word was ever recorded in the literature. You talk about feeling like a fool. I feel like a fool. Because when I look back and I start to tabulate the millions of people in the United States that could have benefited from this treatment that never received it. There are a lot of there is financial incentive not to do this. And I am convinced that is one reason why it has been held hidden. If you asked me in May of last year, did I do this? I'd look at you like you were crazy. No. Now, yeah, I've treated over 400, probably 450 patients so far for osteoarthritis. The light bulb, just like my colleague said, has gone off. Now it's out there. Will it become more relevant as time goes on? Yes. But it's my patients that are going to be making the difference. It's going to be the cliffs that go back to their primary care and they say, I saw Norm Anderson, I had severe osteoarthritis, I'm feeling like a new person. That's why virtually every day I get calls from primary cares and they say, Norm, would you please explain to me what happened here to Mr. So-and-so or Mrs. So-and-so? They came back for routine medical follow-up and I can't believe what's happened here. So you can read medical articles all day long, but until you see it firsthand, it's hard to believe. And I don't know whether you know this or not, but doctors can be egotistical. And if it was not a scam, they would somehow know about it. The fact that that was not publicized means it can't possibly be true. So somehow, heaven must open up the clouds and pour this knowledge directly into an MD's head for it to be legit. In reality, I have treated 16 MDs so far. Many of them have said, you do not need to talk to anyone. We're doing the talking for you, because they're living the results. But the frustration I feel is exactly what you eloquently expressed. It is extremely frustrating to me now that I was that ignorant and didn't listen to my colleagues in Paris, that they should have been started years ago. Do I use the same protocol for Dupuytren's contracture? That's a very good question. No, we don't, but you could. The protocol for osteoarthritis is 3 treatments a week, Monday, Wednesday, Friday for 2 weeks, or Tuesday, Thursday for 3 weeks on average, but we can vary that. The protocol I use for Dupuytren's contracture, as long as it's a fasciitis, which both of them are, I normally use 180 centigrade fraction for 13 fractions. And what that means is that the dose is higher. It can be given every day or it can be split up. In many patients with Dupuytren's contracture, which is if you look at the palm of your hand, the soft portion, and if you bend your fingers, in some patients, you will see cord-like processes show up under the skin. As time goes on, those cord-like processes become like wire. I mean tight. And they connect with the muscles in your forearm. That's what actually controls the movements of your fingers. It's not the muscles in your fingers that are moving it. It's the muscles in your forearm, and they're connected through those tendons. In many patients, the tendons become thick, firm, like wire. And that condition is called Dupuytren's contracture. It contracts the hand. So the first patient I ever treated for Dupuytren's contracture, I actually treated about 25 years ago. It was a dentist in Ocala, and he did his research, and I wasn't treating non-cancers then. And he came to me and he said, Norm, I've looked at the literature in England, and they use radiation constantly for Dupuytren's contracture. So we designed the treatment, and I treated him. He had an identical twin who had Dupuytren's contracture, who was also a dentist. He had to give up dentistry because after the surgery, it was so screwed up, he couldn't hold the instruments anymore, and so he retired. And my dentist friend was about to do the same thing until we treated him. Now, every time I see him, he doesn't wave at me. He goes, hey, how you doing? Because the hand movement is totally and completely normal. Now, the difference is it normally takes a longer time to see the benefit of the treatment for Dupuytren's, because now what we're doing is we're dissolving that fibrous band away, and your body is dissolving a lot of junk that's occurred over literally decades, so it takes time. Same thing. Lederhosen's is, if you're involving, and there's another disease that is the same product, but that's like lumps on the bottom of your foot. And it can also occur with plantar fasciitis. So think of somebody throwing marbles into the substance of your feet. They can get rock hard just like a marble. And boy, you talk about pain, it's unbelievable. Think of it as Dupuytren's in the hand displaced to your foot. Same reaction as far as the radiation, same treatment schedule. Having said that, I normally treat plantar fasciitis the same way that I do osteoarthritis, and it works beautifully. Having said that, if you have it in your hand, most patients who have Dupuytren's contracture also have osteoarthritis at the same time. So when I treat someone's hand, I do not treat a finger, I do not treat a joint space. I treat you from the bed of your fingernails all the way to this portion of your wrist. Every joint space is treated at one time. Why? I don't want you to have to come back over and over and over again. I will cover everything in one session. And since the dose is so extremely low, we don't have to worry about a secondary problem. So that all of you later can come up and go, hey, how are you? Does that answer your question? Okay.
Yeah.
Yes.
I understood what you said. Can you hear me? Yeah. I understood what you said about the inflammation.
Yeah.
What is it doing to the cartilage? Is it actually slowing the erosion of the cartilage?
It stops the erosion.
Is it aborting the erosion?
It stops the erosion. It's the lymphocytes, those cells that are because of irritation. Literally, the reaction is they eat the cartilage away. What I want you to think of cartilage, here's the analogy. I love analogies because I'm a simple-minded person and it's easier for me to comprehend it. But think of putting an ice cube in a glass of water. Representing the cartilage is the ice cube. Over time, the ice cube will gradually dissolve away. That's the same way the cartilage will gradually dissolve away. The difference is in the human body, you don't get more cartilage. When you lose it, it's gone. Now, let me tell you something about your bones. Your skeleton completely remakes itself every 2 years. There are little cells in your bone right now that are dissolving bone away, and there's cells that come right along behind it and lay new bone down. It's like repaving a highway. Every 2 years, you get a new skeleton. So everyone thinks, oh, a bone is a bone, it's just there. No. Of all of the organs in your body, the bones are the most dynamic organ, and that we consider it an organ. It's the most dynamic organ in the human body. It is constantly undergoing change. That's why I have, especially in ladies more than men, because again, they work harder, is that when they come in for arthritis, the nodules that they have at the joint space can be unbelievably large. And the ladies are so self-conscious, they try and hide their hands because of the way their fingers look. I had one lady whose middle finger was so deviated by 30 degrees that it was literally buried underneath the index finger. The hand was worthless. I treated her, 30 degrees of deviation. She comes back for her second cycle 3 months later. Fingers look totally normal. The body had actually remodeled itself back to normal. Now, in no way do we guarantee that that's going to happen. But if it does, I'm going to take full credit for all of this success. But her hand became totally functional. The other nice thing for both men and women is the obviousness of the joint space over time gradually dissolves away, and you get a hand back that looks like you're 20.
Thank you for a very interesting presentation. Are there any relative or absolute contraindications to the low-dose radiation?
Very good question. I don't know of any that would be a contraindication. Now,
or a comorbidity that somebody might have where you can't use
right,
it?
very good question. The only limitations that I can see, let me give you one example, and I limited his field, but we got a beautiful result. I treated one of the top 10 black belt instructors in the world. John came to see me with a very advanced head and neck cancer about 11 years ago. He has black belt schools all over the country. In fact, he's training Tom Brady's kids in black belt. Has a home in Miami, and he had a home in Ocala. He went to the University of Miami. They said, this cancer is way too advanced. You cannot be cured. We'll give you some pain medication, make you comfortable. He came in to see me. I said, I have a totally different way of treating head and neck cancers. I treated him differently. We cured him. John came in constantly after that. And here's the aside. Didn't have an appointment. Comes in unannounced, walks through the office, says hello to all of the staff that treated him, gets in his Cadillac Eldorado and drives away. His Cadillac Eldorado just happened to be Liberace's Cadillac Eldorado, one of a kind. We're in for follow-up. This is 2 years after I treated him. I said, John, you're cured. He said, I know that. He said, I hope you don't mind me coming into the office unannounced, walking through the office and saying hello to everyone. Well, if you know me, I am not going to tell one of the top 10 black belt instructors in the world that he can't come in. The door will open automatically if he gets close. But he said, I can take care of myself physically. I cannot take care of myself emotionally. And every time I come back in here and I shake the hands of the people who cured me, I'm cured again. And I said, you have just paid me one of the greatest compliments I've ever been paid. Well, he has kept coming in for follow-up, and so we talked about arthritis. And he said, Norm, I've got it severely in my neck. I have migraines every day. I have medication lined up in the house. I have migraine medication, pain medication, muscle relaxants. I work through them systematically. In his particular case, because of his advanced head and neck cancer, I had already treated his neck. And so that limited the total amount of radiation that I felt comfortable giving him. So rather than giving him 6 treatments, I gave him 4. Same dose rate. And I knew that was safe because of the small amount. When he came back to see me, he said, I have not taken one of those pills for the headaches, the migraines, since I completed the treatment. And he said, now look, and he moved his neck, and it wiggled around like crazy. He said, now we got to do the hands right away. So bottom line is, that's about the only limitation that I know of, is if it is an area that has received the maximum safe dose, you may want to consider how much more you can give. And I told John, I said, we're only going to give you the 1 cycle, not 3. Fortunately, he got total relief with that 1 cycle of treatment, and he only received 4 of the treatments. So that's about the only condition that I can think of. We have the technology that if I'm treating someone's back, and the spine is an area that many people avoid, but we come in from so many different directions, we avoid the internal organs completely. So the kidney gets nothing if I'm treating the lumbar spine. The same way that if it's thoracic spine, the heart gets absolutely nothing. So the internal organs at risk receive no radiation whatsoever.
I think it's me. Okay. I think you might have just answered my question. You've talked a lot about knee,
Yes.
shoulder, neck,
Yes.
whatever. What about the lower back spine? How
Yeah.
effective is this for that?
Yeah, it's it's dramatic.
It is?
I mean, the back, I'm trying to think, there's, I don't know whether the lady is sitting in the room, but one of the ladies who I treated recently came to see me and said, I got to tell you how I'm here. I go to Dunkin' Donuts every day for my coffee and my donut. For a year, I've seen this older gentleman come in on a walker, stooped over so that the upper half of his body is almost horizontal with the ground. Takes forever to get his coffee and donut, takes forever to get comfortable. Recently, I'm in there. He comes in, no walker, standing straight up, struts to the counter like a soldier, gets his coffee and donut, marches over and sits down, and slaps one leg over the other. She said, when I got my breath, I went over and introduced myself. I've watched you for a year come in on a walker, debilitated, and now you come walking in like a soldier. Yep. I had severe arthritis in my lower back. I saw Dr. Anderson. I got low-dose radiation. I don't need a walker anymore. So that was one example. Another example that we were talking about earlier, and stop me if I've already said this, but lady comes in to see me with her husband, lower back, lumbar spine, severe discomfort, accepts the treatment, goes through the treatment. 6 weeks afterwards, she comes back for follow-up, carrying a goodie bag of gifts for the staff. Big smile on her face, and his. They sit down, the husband starts the conversation and says, we weren't honest with you when we first met. The reason we weren't was because I knew that if I told you how severe my wife's arthritis was in her lower back, you wouldn't give the treatment. She used to sit in the living room every day and cry all day long because of the pain in her lower back. Since these treatments were completed, do you know what she did last week? She went into the bedroom and flipped the mattress. He said, this is the lady I knew 20 years ago, and she's back. She looked at me and she said, I want this treatment repeated. Really? She said, here's the reason why. It's been 20 years since I felt good. I don't know what good feels like. I don't know whether I'm at 25%, 50%, 100%. The only way I'm going to find out is to have the treatment done again. So let's get it done as soon as we can, which she illustrated for me perfectly what happens with the treatment. And that emulates the European protocol. That's why they say 3 cycles. Because in Europe, if someone were to consider surgery, you will not be allowed to go to surgery unless you've received 3 cycles of radiation. Why? Because 7/8 of all of the operations never had to be done if radiation was administered. And when you look at the cost savings, and there's no downtime, why is it not used more often, like the other gentleman said? Does that answer your question? So as far as lumbar spine, I've treated about probably a good 30, 35 people so far to lumbar spine. I don't know of anyone who has not responded. Now, is it 100% on everyone? No. Is it 100% on some of them? You bet it is. Yeah.
Yes, good evening. I just want to ask you, I don't even know if this is something for maybe something for the future.
Yep.
Do you have to have the cancer before you treat somebody?
No.
Okay.
And you can also, and you've raised another good question that you haven't even asked yet. Can you self-refer? And the answer is yes. If you have a cancer, I can accept the referral, but I have to go back through other physicians to get administrative approval. For osteoarthritis, you can direct refer yourself.
Okay.
What we will require if you do not have it is that we will order x-ray documentation of the joint to confirm that there is radiographic evidence of osteoarthritis. But 95% of insurance policies will allow you to self-refer. Some of the others will say, no, you've got to go through your primary care, and then it's an administrative issue that we just deal with.
Okay. Well, I was going to ask you in reference to my grandson. He plays hockey.
Yeah.
He's 6'6", and he's a goalie. So when he falls down to stop a puck and everything,
Yeah.
it's quite a bit more.
Yeah.
So when I talked to him recently, he said they even told him by the time you're 30 or something, you probably have to have your joints replaced
Right.
and so forth and
Right.
knees. He's now getting some type of shots for his,
Right, they will.
I don't know what they call them, but you know, I asked him about going and getting this rejuvenation on the,
Yep.
the,
Stem cells.
pardon me?
Stem cells.
Yeah, okay. So, only have one. Okay.
Yeah. Yeah.
Okay.
Yep.
So I guess my question is this type of something that could help young guys or young kids that are playing these types of activity?
And
where
what you've done is you've set the stage because you're telling me that he traumatizes his body constantly. I'm originally from Toronto, Canada, so I know what hockey's all about. I traumatize my body too. But bottom line is, as you remember the risk factors, trauma is one of the main risk factors for osteoarthritis. The limitation is going to be the age limit. And again, that's an arbitrary goal. Across the entire United States, they use 40 as the minimum age for getting this treatment. We use a minimum of 50 years of age.
Oh, he's got 25 years to go.
Yep. Yep. It's, you know, those are the limits.
After the course of treatment is completed,
Yeah.
are there cases where you have to come back for maintenance?
No, it's 3 cycles and you're done. So, in other words, here's the percentages. If you get 1 cycle, 60% effectiveness. 2 cycles, 90% effectiveness. 3 cycles, 95%. The other thing is the duration of the benefit. 1 cycle, you can expect 6 to 12 months of benefit. 2 cycles, it becomes years. 3 cycles, it's forever. You don't have to worry about maintenance. It's covered.
That's
now,
kind
will
of
there
amazing.
Will there be exceptions? There will be. But again, I don't know of an orthopedic surgeon that's going to offer everyone 100% success. Come on, that doesn't happen in medicine. I'm not going to offer the same thing here. But the results that we have seen have been nothing less than dramatic.
So the results that you get are kind of maintained.
Correct. Again, based upon the cycles. If you were to get 1 cycle and after a year it starts to come back and you say, oh, radiation didn't work, I got to get the surgery anyways. You never completed the full sequence. You'll never know whether it made a difference. That's why, as I indicated, in Europe, you will not be offered surgery until you have the 3 cycles.
Thank you.
You're welcome.
Okay, doctor, here's your last question.
Okay, last question.
All right, okay. I have the mic. So 2 quick yes/no questions. Is it covered by Medicaid? Yes, no?
Yes.
Okay. If somebody has post-surgical hardware in their lower spine, can
Yeah.
you still treat them?
Yes.
Okay.
Now, the real question
Thank you.
becomes, how much did the surgery do? Have they addressed the full issue? And again, especially when you're dealing with the spine, it can be what we call multifaceted. Your pain can be due to a number of conditions. This is only going to address osteoarthritis. If the basis for some of that pain is mechanical, don't expect the radiation to make a difference. But because of the low doses, if the question is, can I treat through hardware? The answer is yes. I can go through 13 feet of concrete with this energy. Nothing they put in your body is going to stop me.
Okay, let's give Dr. Anderson a big hand.
Can I just say one thing? Let me just say one thing. I had my plantar fasciitis and my bone spur taken care of. I had my knee taken care of. My wife had her hip taken care of and her back taken care of. It works, guys. Believe me when I tell you. Works better for some people than other people. I only needed 1 treatment on my plantar fasciitis, 2 on my knee. My wife's had 3 on her back. She is 90% better than she was. So That's all I can tell you. Everybody make their own decision. But Dr. Anderson, thank you again, buddy.
Thank you all for coming. We have donuts in the back.
You know where he's located in the villages? Is he right by the hospital there?
That I don't.